All right, I believe this is going to be the fifth lecture in the cardiovascular series, and we're going to start off with electrophysiology of the heart. Cardiac cells, we've talked already quite a bit about, but we're going to continue our discussion. They are going to possess not only the property of conductivity and contractility, but also automaticity. And these cardiac electrical cells, particularly the SA node, AV node, and Purkinje network, are the pacemakers of the heart. They possess the most automaticity of all the fibers. Cardiac cells can and are capable of generating and conducting electrical impulses without external stimulation from the brain or spinal cord. These electrical impulses are the result of brief but very rapid flow of positively charged ions, particularly sodium and calcium, and to lesser extent other positively charged ions like magnesium, into the cell, inside the cell membrane, and into the cytoplasm. The difference in concentration of these ions across the cell membrane at any given point in time is called the electrical potential, okay, or voltage, and is measured in millivolts. Let's talk about the resting state of the cardiac cell and what's going on when the cell is not contracting. When a myocardial cell is in a resting state, more sodium, positively charged cations, are present outside the cell. Why? Because the sodium-potassium pump has worked to cause that unequal concentration. At the same time, a high concentration of negatively charged ions, primarily organic phosphates, organic sulfite ions, and protein ions, are mixed with a smaller concentration of potassium ions on the inside of the cell. So the inside of the cell is relatively more negative in relation to the outside of the cell. Under these conditions, a negative electrical potential exists across that cell membrane. More positive on the outside, more negative on the inside. This is made possible by the cell membrane at its resting state being impermeable to sodium ions outside the cell, potassium ions leaving the cell, and negatively charged ions leaving the cell. When a cell membrane is impermeable to an ion, it does not permit the free flow of ions across it. So during the resting state, all that is going on to achieve this unequal charge that occurs across the cell membrane. The resting cardiac cell can be depicted as having a layer of positive ions across the cell membrane and an equal number of negative ions lining the inside. When the ions are aligned in this way, the resting cell is meant or is said to be polarized. So when you have this affair going on, the cell membrane is said to be polarized. It's polarized because one side is positive, the other side is negative. The electrical potential across that cell membrane during its resting state is called the resting membrane potential. The resting membrane potential in atrial and ventricular syncytiums and specialized electrical cells, which are the SA node, its branches going down to the AV node, is normally, and you need to know this, minus 90 millivolts for a cardiac cell. It is somewhat less in SA and AV nodal cells, around minus 70 millivolts. This is very important because the SA node and the AV node do not have to achieve as much of a negativity on the inside of their cell membranes to create an electrical impulse to be conducted. And so these cells become quicker at generating electrical conduction of impulses than the other cells in the heart for that reason. All right, so hopefully everybody has a grasp of what a resting membrane potential is and what's going on when the cardiac muscle cells are not contracting. Now let's talk about the next phases, which are depolarization and repolarization. When stimulated by an electrical impulse, the membrane of a polarized myocardial cell becomes permeable, all of a sudden becomes permeable to sodium ions. So the sodium channels open up and the sodium flows inside the cell. So once that cell membrane reaches that minus 90 millivolt magic number, the sodium channels open up and sodium flows inside the cell. And it will continue to flow inside the cell until those charges are equal across that cell membrane. When the membrane potential drops to about minus 60 to minus 70, large pores in the membrane momentarily open. These channels allow the free flow of sodium across the cell membrane, resulting in a sudden large influx of positive ions, and electric charge flows inside the cell at the same moment. The moment the concentration of positive charged ions within the cell reaches that of outside the cell, the membrane potential reaches zero, and those sodium channels close. The membrane is next going to be termed depolarized. Before the sodium flowed in, it was resting membrane potential, and now it's depolarized. The influx of positively charged sodium ions continues until overshoot occurs, and the inside of the membrane reaches a point of about positive 30 millivolts. At that point in time, the cell is completely depolarized and the sodium channels close. The cells of the SA and AV nodes, on the other hand, have slow calcium-sodium channels that open when the membrane potential drops to about minus 50 instead of minus 60, like the cardiac working muscle cells that I just mentioned. They permit the entry of positively charged ions, which are sodium and calcium, into the cells during depolarization at a slow and gradual rate, not a sudden big influx like the cardiac working contractile cells do. As soon as a cardiac cell depolarizes, positively charged potassium ion gates open up and potassium flows out of the cell at a fast rate. This is termed repolarization, getting the positive and the negative charges back where they should be. And this involves a complex exchange of potassium, sodium, calcium, and all of these ions across the cell membrane. And it must be noted that the electrical positive potential to a resting cell membrane is more positive than is external to a depolarized cell. Okay, so if you pull up a picture of a depolarized cell membrane of a cardiac working cell, you can see this happening. How sodium flows rapidly inside the cell until it reaches about zero, and then the calcium gates open up and continue to flow in until the inside of the cell reaches a millivolt potential of about plus 30 millivolts before the potassium gates open. Now, on the other hand, at the same time this is occurring, the electrical conduction system, SA nodes and AV nodes in particular, are constantly leaking the sodium inside their cells and constantly generating impulses because of being extra leaky to sodium back inside their cell membranes. So a little bit different in how the workings of the cardiac muscle cells versus the electrical conduction cells depolarize. Both of them involve the same ion exchange, however. Depolarization of one cardiac cell acts as an electrical impulse on adjacent cells, causing them to depolarize. Now, how do adjacent cells get depolarized almost at the same time that one cardiac cell gets depolarized? It's by those intercalated discs that join all of the cardiac syncytiums together. As the cells repolarize, another electric current is produced that is similar to, but opposite in direction to the first one. The direction of flow and the magnitude of the electric currents generated by depolarization and repolarization of the myocardial cells of the atria and then of the ventricles can be detected by surface electrodes. So if we put surface electrodes on top of cardiac working muscle cells, we could actually measure the millivolt wattage that is being produced by each depolarization and then each repolarization. This depolarization, repolarization cycle is depicted on an EKG, and that's what we're going to learn how to read. Threshold potential is the next term that we're going to discuss, and it starts out like this. A cardiac muscle cell does not need to be repolarized completely in order to accept a new charge and a new depolarization. Okay, so that is minus 90 millivolts or minus 60 millivolts, depending on which type of cardiac cell we're talking about, does not necessarily have to be completely achieved before this cell opens up its sodium gates and allows a new stimulus to be carried inside the cell. The cells of the SA and AV nodes can be depolarized when they have been repolarized to about minus 30 or 40. The rest of the cells of the electrical conduction system, however, can be depolarized when they reach a minus 60 to minus 70 millivolt charge. And that takes an extra strong stimulus, not just a normal stimulus, to cause an early new depolarization to occur, but it can happen. The level to which a cell must be repolarized before it can accept another new stimulus to depolarize is called the threshold potential. It is important to note that a cardiac cell cannot generate or conduct an electrical impulse or be stimulated to contract until it has been repolarized to its threshold potential. If it has not reached that threshold potential yet, meaning that enough potassium ions have not flown out of that cell to create that minus negative charge potential, then that cell, no matter how strong that stimulus is applied to it, it will not be able to accept it and cause it to contract. All right, cardiac action potential is the next term. A cardiac action potential is a representation of the changes that the cell membrane goes through in order to create contraction and relaxation of that cardiac muscle cell. The cardiac action potential can be divided into 5 phases, 0 through 4. The following are the 5 phases of the cardiac action potential of a myocardial cell. And if you type in cardiac action potential on Wikipedia and take a look at these 5 phases in a graphic schematic while I talk about them, that would be great. Phase 0 is the depolarization phase. It is the sharp, tall upstroke of the action potential because sodium gates are open and sodium is flowing inside the cell at a rapid rate. As the positively charged ions flow into the cell, the interior of the cell becomes electrically positive at some point up to a plus 30 millivolts, as we talked about earlier, with respect to its outside cell membrane. During the upstroke, the cell depolarizes and begins to contract. Now take a look at phase 1. It goes back the other way a little bit, doesn't it? This phase is called early rapid repolarization. This is when the cell tries to equalize the charges and causes an early outflow of positive ions out of the cell to try to equalize those charges. This is following the rapid inflow of sodium. The sodium gates shut, and there's a loss of potassium by the sodium-potassium pump, pumping potassium, or not the sodium-potassium pump, I'm sorry. The potassium gates are opening, trying to let potassium out of the cell to start repolarization. But before repolarization can be completely accomplished, the calcium gates open, as well as the sarcoplasmic reticulum sacs open and allow calcium to influx into the cell cytoplasm to hold that sustained charge, okay? And that is phase 2. It's called the plateau phase. This is a prolonged phase of slow repolarization following the action potential of the myocardial cell. Phase 3 follows phase 2, and this is the terminal phase of rapid repolarization. This is when potassium gates are fully open and potassium is flowing out of the cell at a rapid rate. Okay? Phase 4 is the last phase, and this is the period between action potentials when the sodium-potassium pump is pumping sodium out of the cell at a rate of 3 to 2, potassium's being pumped back into the cell using ATP energy, trying to get the proper ratio of sodium on the outside of the cell and potassium back on the inside. So that's what a cardiac action potential cycle looks like on paper. Now look underneath that cardiac action potential, and you can see how an EKG wave corresponds with the cardiac action potential. You can see that as the sodium gates open, the Q wave is manufactured on the EKG, and then during the plateau phase is when the big R wave is formed, followed by the rapid efflux of potassium to create the S wave, and then you've got the T wave as the final act of repolarization where potassium is flowing out of the cell at a rapid rate. The isoelectric line between cardiac cycles on the EKG is when the sodium-potassium pump is trying to achieve a resting membrane potential again. All right, refractory and supernormal periods. The time between the onset of a depolarization and the end of a repolarization is customarily divided into periods where cardiac cells can or cannot be stimulated. These are refractory periods. You need to know refractory periods. There are 2 of them, absolute and relative refractory periods. The refractory period of cardiac cells begins with the onset of phase 1 of the cardiac action potential and ends with phase 3. On the EKG, it extends from the onset of the QRS complex to halfway through the T wave. So divide that T wave into half, and that is the extent of the refractory period. Now, the first part of that refractory period is the absolute refractory period, meaning while this cell is already depolarizing and in early repolarization, that cell cannot accept another stimulus and create another cardiac cycle or can cause cardiac muscle cells to contract no matter how strong the stimulation is. But that last portion of the refractory period, from the end of the S wave to the first half of the T wave, is called the relative refractory period, whereby a very strong stimulus that arrives early on that cardiac muscle cell, if it is strong, stronger than normal, can create another cardiac cycle to begin. And that's what the relative refractory period is. So know the difference, okay? Excitability and automaticity is the next terms I want to go over in detail. When a cardiac muscle cell is polarized and it is resting, in order for it to depolarize, it must possess the property of excitability. Can this muscle cell accept a nervous impulse, basically? And cardiac cells have this property because they have the sodium-potassium pump, sodium, calcium, and potassium gates, which creates that unequal charge across that cell membrane so that it can accept and transmit impulses. The capability of a cardiac cell to depolarize spontaneously during phase 4 or to reach the threshold potential stimulated in phase 4 is called the property of automaticity. That SA node is capable of generating a constant stimulated generation of nervous system impulses at a rate of 60 to 100 times a minute from now to eternity, as long as that thing is fed adequate oxygen and it is able to remove all of the waste products that it uses. Oh, excuse me. So that is a property of automaticity. This SA node requires no outside stimulation from the sympathetic nervous system nor the parasympathetic nervous system. However, fibers from both systems do land on that SA node and can change its behavior, but it is not required for that SA node to fire on a 60 to 100 beat per minute system. Spontaneous depolarization does depend on the ability of the cell membrane to become permeable to sodium in the beginning. This allows a steady leakage of sodium ions, as I've said several times, causing this cell membrane to reach its resting membrane potential and then depolarize. All right. Dominant and escape pacemakers of the heart. We've already alluded to this. Normally, pacemaker cells in the heart have the fastest firing rate control of any other cardiac cell in the system. Each time these pacemaker cells generate an impulse, the slower firing latent pacemaker cells are depolarized before they can do so on their own. So as long as the SA node is firing, it is firing at a rate faster than the inherent rate of the AV node or the Purkinje fibers. So they cannot take over the pacemaker function of the heart unless the SA node fails. This is called overdrive suppression. The SA node has the ability to overdrive suppress the other pacemaker cells of the heart. The SA node is normally the dominant and primary pacemaker of the heart for that reason, because it possesses the highest level of automaticity. That is, its firing rate is 60 to 100 times per minute. If the SA node fails, the AV node, once again, has the ability to generate automaticity electrical firing rates at a rate of 40 to 60. And if the AV node then fails, the Purkinjes fire at a rate of 20 to 40 times per minute. So make sure that you know those ranges for each of the pacemaker centers of the heart. Okay, mechanisms of abnormal impulse and functioning. All right, under certain circumstances, any part of that electrical system of the heart can become an abnormal pacemaker of the heart. And that's when we see abnormal beats occur on EKGs. These latent pacemaker cells are non-pacemaker cells However, they are conductive fiber cells within the normal pathway between the SA node and the Purkinje fiber network. Such pacemaker cells that fire on an abnormal basis are called ectopic pacemakers, or ectopic beats is what they produce. The result can be abnormal ectopic beats such as tachycardias, atrial fibrillation, atrial flutter, premature ventricular contractions, premature junctional or atrial contractions. Any of those are considered in this group. These arrhythmias are identified according to their location, where they start, and the three basic mechanisms that are responsible for ectopic beats. And if they're not just single beats, they can be entire rhythms that are ectopic rhythms, are enhanced automaticity, reentry phenomenon, and triggered activity. Now let's take a look at each of those three factors. The first one is enhanced automaticity. This is an abnormal condition of latent pacemaker cells, normal pacemaker cells that should be sitting there responding to what the SA node tells them to do. And they increase their firing rate beyond what their inherent rate is supposed to be. This occurs when the cell membrane suddenly becomes abnormally overpermeable to sodium and calcium ions, which is not normal for that particular part of the heart. The result is an abnormal high leakage of sodium into the cell, and depolarization follows. Even cardiac muscle cells that do not ordinarily possess automaticity, non-pacemaker cells is what I'm talking about, just regular cardiac working contractile cells, do not ordinarily possess automaticity, but they may acquire this property under certain conditions and start to depolarize spontaneously. And this is when we see atrial, junctional, and ventricular rhythms and beats that are going to cause the patient to not feel well. Common causes of this enhanced automaticity are an increase in catecholamines. Someone takes an overdose of amphetamines like epinephrine-like products. Digitalis toxicity, a lot of patients are on digitalis, and administration of atropine. And we will learn that atropine is a parasympatholytic drug, which wipes out the vagus nerve and allows the sympathetic nervous system to run rampant in our bodies. In addition, hypoxia, hypercapnia, myocardial ischemia, or infarction, as well as overstretching of the heart, hypokalemia, low potassium levels, hypocalcemia, which is low calcium levels, and heating or cooling of the heart may also cause enhanced automaticity. The next factor is reentry. This is a condition in which the progression of an electrical impulse is delayed or blocked. And this impulse can be delayed or blocked through one or more parts of the electrical conduction system, but continue to go normally through the rest of the conduction system. Remember, after the impulse leaves the AV node and enters the bundle of His, it goes down the septal wall along two branches, the left and right bundle branch, and then it branches out further. So any of those branches can be blocked, but yet the rest of the impulse can conduct normally. And this can stimulate a reentry pattern, whereby the normal conduction depolarizes about half or a portion of that ventricular syncytium, for example. And remember, all of the cells in that syncytium are ultimately linked by intercalated discs. So what happens is normal conduction, let's say, goes through the right heart along the right bundle branch block, but let's say the left bundle branch is completely blocked. Well, the right ventricle is stimulated and fires, but the impulse is going to spread eventually along the Purkinje network to the left ventricle to stimulate those contractile fibers to contract and eject blood. So there's going to be firing of the right ventricle and then a later firing of the left ventricle, because the entire syncytium is interconnected. Even though the impulse didn't travel normally, it will still get there through alternate pathways. And that's what reentry means, is the impulse will get there at a delayed rate through a alternate pathway. It's kind of like anastomosis of blood vessels. This can result in delayed antegrade and retrograde conduction. So the impulse will travel through that syncytium, but it will not travel in a normal pattern. So therefore, the heart contractile cells will not be coordinated correctly to eject the maximum amount of blood that they are normally coordinated to do so. This delayed impulse depolarizes some areas prematurely and depolarizes other areas too late. So you have a total incoordination of the pump in that syncytial network. Myocardial ischemia as well as hyperkalemia can cause this, and they are the most common causes of reentry phenomenon. Another cause of reentry mechanisms is the presence of accessory conduction pathways. Remember in my previous lecture, we talked about Mayhem fibers, James's fibers, we talked about the WPW pathways. All of those are alternate abnormal pathways, which can overstimulate the heart too rapidly and cause it to fibrillate or to flutter. And that is another type of reentry phenomenon. The reentry mechanism can result in abnormal generation of single or many electrical stimuli in any area of the heart, atria, AV junction, the bundle branches, and or the Purkinje networks. This produces atrial, junctional, or ventricular ectopic rhythms. Such reentry tachycardias are very difficult to treat in many cases, and it's very difficult to break this reentry circuit once it gets started. The abnormal beat will always follow a normal one, and the time frame will be at the normal fixed interval of time. This is called fixed coupling, bigeminal rhythms, or simply bigeminy. So if you have a bigeminal rhythm, you will have a sinus rhythm, for example, but intertwined in that sinus rhythm, you've got early beats or even early rhythms going on from these reentrant pathways. So you'll be a beat, 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 but bigeminal early beats. So you'll have beat early, beat early, beat early. And those are like PVCs that occur every other normal beat, PJCs that occur every other normal beat, or PACs, which are atrial contractions that occur every other beat. Triggered activity is the next one that we talked about. Triggered activity is an abnormal condition of latent pacemaker and myocardial cells in which the cells can depolarize after stimulation by a single electrical impulse. And it can be stimulated to beat more than once after that single electrical impulse. The level of membrane action potential spontaneously increases after the first depolarization until it reaches threshold potential, causing the cells to depolarize once or repeatedly. This phenomenon is called after depolarization and can occur almost immediately after depolarization. And this usually occurs in phase 3 of the cardiac action potential. That's when the potassium gates are open and depolarization of the cardiac muscle cells is occurring, if you'll recall. Triggered activity can result in atrial or ventricular ectopic beats, either one, occurring singly, in groups, paired, or in couplets, which are groups of 3 or more beats in succession. Common causes of triggered activity, like those of enhanced automaticity, include an increase in catecholamines, digitalis toxicity, hypoxia, myocardial ischemia, or myocardial infarct, or overcooling or overheating of the cardiac muscle cells, I should say. Remember the terms Starling's law of the heart? Remember, Starling's law was when we have a heart that attempts to eject all blood that is presented to it. So if 70 cc's of the blood returning to the heart is presented to the right atrium and is received ultimately into the left atrium from the pulmonary circulation, entering the left ventricle, the left ventricular chamber will attempt to eject all 70 cc's of that blood if it can. Okay? And the reason for that is just like a rubber band. The further cardiac myofiber cells are stretched, the harder they will contract, just like a rubber band. If you hold a rubber band and stretch it to its potential and let it go, it will snap harder than if you just barely stretch it. Okay? So the more blood in the heart, the further it stretches, and then the harder it can contract. So the more blood in, the more blood out, because the heart pumps harder, the more blood that is in the chambers of the heart. Okay? Less in, less out. That's Frank Starling's law of the heart. Now, there is a breaking potential. If the heart is overstretched from way too much volume, more volume than the heart can handle, then it just sits there in a relaxed state and cannot contract forcefully. That is called congestive heart failure. Okay? All right, nervous control of the heart is the last thing that we're going to cover, I do believe, and then we're done with our lecture. The heart is under constant control of the autonomic nervous system. Both the sympathetic and the parasympathetic nervous system has fibers that leave the medulla oblongata in the brainstem and go directly to the SA node and the atrial networks of the heart. The sympathetic nervous system ultimately stimulates adrenergic receptors in the heart, and we've already learned what those receptors are. They are called beta-1 receptors, right? The parasympathetic nervous system has cholinergic receptors. Okay, those cholinergic receptors are called muscarinic receptors on the cardiac muscle cell walls. Each produce opposite effects on the heart when they are stimulated. These two systems work together to cause changes in cardiac output to maintain that all-important homeostasis. Okay? Nervous control of the heart originates in 2 separate nerve centers in the medulla oblongata. One is the cardioacceleratory center. Cardioacceleratory means speed up, so guess what? The sympathetic nervous system originates there. And the cardiodeceleration or cardioinhibitory center is where cranial nerve number 10, the vagus nerve, the main parasympathetic nerve, originates in the medulla. Impulses travel along nervous pathways to innervate the SA node and atria, as well as the AV junction, and to a smaller extent, the ventricles and the Purkinje fibers. Another important cardioinhibitory center is in the carotid sinus, right here in your neck. It is a slight dilation of the common carotid artery, and it's located at the point where it branches into the internal and external carotid arteries. It contains nerve endings that are important regulator of blood pressure. Those are where your baroreceptors are, and we've talked about those in the past, which can indirectly affect heart rate. As the blood requirements of the body change, so does the heart rate and force of contraction, speed of conduction, and therefore cardiac output. Stimulation of the sympathetic nervous system produces the following adrenergic effects to occur on the cardiovascular system. An increased rate of firing of the SA node. What term do we give increased speed of conduction? Dromotrope, right? So it increases the SA node's excitability as well as its property of automaticity. Number 2, it increases conductivity and the electrical impulses throughout the atria and ventricles. Again, that is increased dromotropic effect. It also causes an increased force of contraction in both the atrial and ventricular syncytiums. That is increased inotropic effects, okay? Finally, it increases the speed of firing at the rate, or speed of firing of the SA node, which is chronotropic effect. Increased heart rate is increased chronotropic. The result is an increased heart rate, increased cardiac output, and increased blood pressure. This is accomplished by direct stimulation of the cardiac cells and indirectly by the release of catecholamines such as epinephrine and their effect on the cardiac cells. Now let's talk about the vagus nerve, the parasympathetic nervous system. It produces the following effects. A decrease in the firing rate, so negative chronotropic effect on the SA node, and the escape as well as the ectopic pacemakers in the AV node as well as the atrial networks. Number 2, it slows conduction of electrical impulses through the AV node, even more so than they're already slowed. So that is a negative dromotropic effect. The result is a decrease in heart rate, cardiac output, and blood pressure. Sometimes it can even produce an AV total block, okay? And there are various degrees of AV block that we'll learn about when we get into EKG interpretation, okay? There's complete heart block. There's a Mobitz 2, which is a second-degree cardiac heart block. And there is a Mobitz 1, which is also another type of second-degree heart block, and then a first-degree AV block. All of those can be produced by overstimulation of the parasympathetic nerve, the vagus nerve on the heart. So what can we do to reverse that besides apply a pacemaker and overdrive pace these patients by electrical stimulation externally? We can give them a drug to wipe out the parasympathetic nervous system temporarily, and that drug is called atropine. It is a parasympatholytic drug. The following maneuvers and bodily functions can also affect heart rate, blood pressure, and cardiac output. First of all, if you put pressure on the carotid sinus and rub that, what is that going to do to those baroreceptors in the carotid sinus? It's going to stimulate them, right? Okay, so that's going to affect heart rate and speed of conduction and ultimately blood pressure. So if you stimulate that carotid sinus enough, those impulses will be sent to the heart to slow the heart rate down, decrease blood pressure, and speed of conduction. The Valsalva maneuver is the act of straining against a closed glottis, very similar to what you do right before a cough, to generate a cough. When you are constipated and you're trying to force out a large bowel movement, all of those are Valsalva maneuvers, usually accomplished with the head and a head down, chin to chest position, and holding your breath and trying to blow air out of your glottis with it closed. That's a Valsalva maneuver, and we can use that maneuver out in the field to try to slow down an overly rapid heart rate. Distension of the urinary bladder is another type of Valsalva maneuver. We're not going to do that out in the field, but you know, if you're driving long distances and you can't find a restroom and your bladder is over distended, that can cause a Valsalva maneuver, and it is dangerous because it can actually drop your heart rate so much so that you can pass out. You'll run a lot of people over your time as a paramedic in the bathroom. A lot of guys that are shaving their necks in the mornings, guess what they can do? They can overstimulate their carotid artery, and they can go into a parasympathetic nervous system overdrive, drop their heart rate, and they can pass out. I ran a little lady years ago with really short, fat neck. She had big old wide pearls around her neck. That was a really tight choker, pearl necklace. And she was sitting there praying, and the pressure of those tight pearls on her neck with her head in a head down position praying caused her to pass out. And once I got her in a head tilt chin position, got her some oxygen and got her some atropine, she came right out of it. But that happens in those situations. Nausea, vomiting, bronchial spasms, sweating, fainting, hypersalivation are all examples of overdrive or over stimulation of the parasympathetic nervous system. Just remember that the drug atropine is a parasympatholytic and blocks that parasympathetic nervous system. Okay, I hope you learned quite a bit through this section. It's quite a bit of lecture, so I hope you watch it over and over again because it's a very important section. And Randy and Casey are going to take it from here and teach you how to read EKGs and take you into some scenarios and also some cardiac related medical emergencies, and so you can learn how to use this information to treat those patients. All right, study hard, gang, and I'll see you soon.